ocular vertebral spectrum. Ocular findings in this include epibulbar dermoids, like we just saw there, lipodermoids, Duane syndrome, eyelid coloboma, et cetera, et cetera. There are other malformations that also go with craniofacial microsomia. Now, what's this about Goldenhar syndrome? In 1952, Maurice Goldenhar described an association between ocular abnormalities, particularly epibulbar dermoids, malformations of the ear, and dysostosis of the mandible. But it's not really clear what Goldenhar syndrome refers to, and there's not really a clear consensus on what it is. What it really is, it's typically hemifacial microsomia with some ocular defects and some auricular defects. Sometimes they have spinal defects, sometimes they have cardiac defects, sometimes they have the renal defects. The key concept is that craniofacial microsomia can be associated with ocular, auricular, and vertebral defects, particularly the hemifacial microsomia. And people use the term Goldenhar syndrome, but it's not really clearly defined what that is. It's really more precise to call it craniofacial microsomia or hemifacial microsomia. Okay? So how do we manage this? What do you think, Dr. Khalid, if we remove this surgically? What do you think? Well, this epibulbar dermoid. What do you think will happen to this astigmatism?
The astigmatism, I'm assuming it will be less, or it will change.
Yeah, that's what you would think. But in fact, in my experience with these, the astigmatism doesn't change. So we don't remove these because of the astigmatism, because if we were to do that, we're wrong. Because when we remove them, you would think that it's logical that maybe it would, but in fact, this is a congenital lesion. It's actually an in utero lesion, and the changes that happen to the eye, I'm telling you from experience, they persist even when you remove these. So we don't remove these to get rid of the astigmatism. If we're aiming to get rid of the astigmatism from removing it, we're going to be disappointed. So actually, we did remove this, and his refraction didn't change at all, as expected. Just on the set, go ahead.
So the cylindrical refraction did not change at all, even with the removal.
No. Because it's true that this compression has compressed things, but the fact is this happened in utero, and the structural changes are permanent. I mean, even if you remove it, it's too late. That's my experience with this, with these epibulbar dermoids, and that's pretty much in the literature as well. Of course, if you had a new compressive lesion that's inducing a new astigmatism and you remove it, of course, that's going to happen. But we have to remember, this happened, very early in embryogenesis. So it actually changed the structural makeup of the collagen. And of course, amblyopia is the huge problem in these cases. So, I'm not going to go into optics, but this is something that you just have to know, and you just have to memorize it. It's confusing, but there's no escape from it. When we talk about the cornea, we talk about meridians of power. And when we talk about a 90-degree meridian of power, that's where the steepness is. Or 180 degrees, if it's steep in 180 degrees, that's where the power is. And we're talking about meridian. Here, this is showing a steep meridian at 90 degrees. Now, when we correct this with an optical lens, we talk about the lens in terms of cylinder, and we talk about it in terms of axis. And the axis is actually 90 degrees away from the actual power. So here is a plus power at 90, steep cornea at 90, but we correct it with a minus cylinder at 180. And even though this lens is labeled minus cylinder at 180, the true minus power is actually at 90 to match with this. It's very confusing. But be precise in the terms. When we talk about cornea, we're talking about meridian, and that's where the actual power is. When we talk about lenses, we're talking about axis, and the true power is 90 degrees away from the axis. So this -2 at 180, the -2 power is actually at 90. The -2, 180 axis, the minus power is at 90. But when we talk about +2 at the meridian, that's where the power is. It's confusing, but you just have to know it. There's no escape from it. Just, related, here's actually an email consult that I got during the pandemic. Somebody called me, they said they noticed that their daughter has a lesion on the eye, and they just noticed it like 6 months ago. So I said to send me a picture. And here's a picture. And this, of course, it's a picture, I haven't seen the patient, is most likely a lipodermoid, because that's the typical location of lipodermoid. And it was probably there a long time, and they just didn't notice it until recently, or maybe it grew a little bit. There are other things in the differential, but this is most likely a lipodermoid. It certainly has the appearance of it, as opposed to an epibulbar dermoid or a dermoid cyst. And this child, actually, I just saw yesterday. Again, another call. Baby has a lesion in the eye. This one was in the eyelid. So we had them bring the child in because they were very scared. And you can see this lesion here. And this is the typical site of a dermoid cyst. And indeed, when we palpate this, it's firm and rubbery. It's a dermoid cyst. We confirmed it with the ultrasound. That's certainly what it is. The major differential in something like this is an cephalocele, but thankfully we have UBM now, and we can confirm the cystic nature. It's very unusual to diagnose a dermoid cyst at this age, but these parents were really, really looking at their child very carefully and palpating, and massaging the child's eyes actually in their eyelids, and they felt it. They actually didn't see it, they felt it. Then they looked carefully and they saw it. So that's the first segment of cases. Now we're going to move to strabismus, and I need an R3 for this one. Can we have an R3?
I'll have like 5 seconds. If no one's participating, I'm going to choose.
Thank you, Dr. Khan, for accepting the invitation. I just wanted to intrude while you are waiting for somebody to volunteer.
Oh, nice to hear your voice.
Thanks.
Nice to hear your voice, Dr. Hind.
So if you look at participants, you can, maybe it's difficult for you to pick, but we do have like 55 participants. So you should be able to get somebody to answer you.
This is easy. This is no hard questions here. It's all easy. I just need somebody to ask a general question. That's all. I don't want to ask Khalid again.
No, yeah, I mean, we should. There are participants, by the way, from outside KSU, and you are most welcome to contribute. So just raise your hand, please.
Okay, can we have Dr. Walid Sarhani?
نعم. Yes.
Dr. Walid.
Yes, Dr. Khan.
Yes, okay. So this is very simple. You get a phone call, the child's eye turns outward. What kind of things do you think about?
So in this case, I would think about the differential diagnosis would include intermittent exotropia, sensory exotropia as well.
Sure, definitely. Definitely. Intermittent exotropia is a big one. Sensory exotropia. It's an 11-year-old girl with intermittent exotropia. And what's the approach to intermittent exotropia, just in general?
So first of all, I'll start with history. I'll ask how much of the day does the exotropia last, and if it is cosmetically apparent to the family, is it worsening by daydreaming or by fatigue? If there is any history of surgery previously, how's the control?
Sure.
Yeah.
Is there any role, so surgery is indicated if it's there the majority of the time?
Well, the indications of surgery include if the patient has poor control over the XT, or if it is lasting more than 50% of the time, then surgery is indicated.
Okay. Are there any treatments other than surgery?
Yeah, we have, before surgery, we have some options like over-minusing the child to increase the accommodative convergence.
Okay, very good. So here is this child. She's 11 years old, and this is her measurements at distance, and she has good vision with her glasses. And it's present, it's getting worse. Is there anything else you need to know about this patient?
How's the control of the XT on physical examination?
She controls it, but she breaks very easily. But is there any other strabismus measurement that we need, or is this enough?
We need the refractive cycloplegic refraction.
Sure.
And we would like also to do the patching to see if it is pseudo divergence.
Yeah. Well, we also, to know if it's pseudo divergence or divergence, we also need to know the near deviation also.
Yes.
And in intermittent exotropia, what do we usually see? Do we usually see that the near is more than the distance, or the distance is more than the near?
In the basic XT, the distance is equal to the near.
That's true. In basic, this distance is equal to near. But in the most people with exotropia, intermittent exotropia, in general, in general, most people with esotropia, if there's a difference between distance and near, the near is more in esotropia. In intermittent exotropia, in general, if there's a difference, which is more, the distance or the near?
The distance is more.
Absolutely. It's usually the distance is more. So when we do a more complete exam on this child, actually the near is more. Okay?
Mm-hmm.
And, this is the orthoptic exam. So what we have to do is we have to do this patch test, as you mentioned, but this is still maintained. So we have an exotropia where the distance is less than the near. This is unusual.
Yeah.
The usual situation is in exotropia, either the distance and the near are the same, and then when you patch them, or do a patch test, maybe the distance will become more, or from the beginning, the distance is more than the near. Actually, it's very common to see that they have a big distance angle, and the near, there's no angle at all, unless you do a prolonged patching. So this is unusual.
So here the diagnosis is divergence, convergence insufficiency, or convergence weakness.
Yes, it's convergence insufficiency. Very good, very good. So in exotropia, often, as I just said, the distance is greater than or equal to the near. And usually if they're the same, you do a patch test, then the distance becomes more. That's the typical situation. Less common, we have the near greater than the distance, which is what we have in this girl. And when we have the near greater than the distance, there are two types. One is something called, you can consider fusional convergence insufficiency. These patients are pretty much straight in the distance, and they just have a problem at near, and they actually complain of diplopia. These patients respond to orthoptic exercises. This is the type of strabismus that responds to orthoptic exercises, the pencil push-ups, if you've heard of them. This is the one form of strabismus that responds to exercises. The other type of intermittent exotropia near greater than distance, is the low ACA ratio. And this is probably one of the worst types of intermittent exotropia because they're difficult to control and they typically require surgery, and the surgical results are not as good as the other forms of intermittent exotropia. These patients with the low ACA ratio typically have an exotropia at distance and at near. The fusional convergence type, typically in the distance, they're more or less straight. They just have their problem at near. So when we talk about the convergence insufficiency, intermittent exotropia, we have to distinguish, is it fusional convergence insufficiency or low ACA? Now, there have been many suggestions about what kind of surgery to do for this low ACA ratio exotropia. Some people say to do recess-resect. Some people say biased recess-resect, which means doing more resection than normal and less recession than normal. Some people say you have to do medial rectus resection. Some people say you have to do lateral rectus recessions. Some people say it's slanted so that the inferior pole is further back than the superior pole so that you get the near deviation more for the recession, and for the resection, vice versa. When you see so many suggestions like this, you know what it means? It means that none of them work well. It really depends on the fusional ability of the patient. I'm sure that these different strategies can work among a lot of different patients. For me, I don't really believe in this biased recess-resect or slanting. It really doesn't make sense to me, because when you do a recession or when you do a resection, you influence the distance and near both by a certain percentage, and these ideas that you can slant it and affect one more than the other, it's not really clear that that's true. There's been a lot of work recently that suggests that it doesn't make a difference. So for me, I do lateral rectus recession less than the near angle, but higher than the distance angle, with infraplacement to induce a V pattern, because when we infraplace, we induce a V pattern, and reading is very important. So it helps them to converge at near. Remember, they have more exotropia at near than at distance. And putting them in that range, if they have a good fusional capability, that's enough where they can control their deviation. But this is a tricky form of intermittent exotropia. It's not the common run-of-the-mill intermittent exotropia that we see all the time. And so for this girl, what did I do? I did what I prefer. I just did lateral rectus recession for more than the distance angle, but less than the near angle, and infraplaced as well. And you can see here, right after surgery, she has a small esotropia and an exophoria, which is exactly what we want. And she has a V pattern because we infraplaced. That V pattern is important because when we look down, that's when we converge, that's when we're reading. Here was her pre-op. Look how both the 25 at distance and the 45 at near collapsed, even though we didn't do any slanting, we didn't do any of this biased recession that's in the literature. And here she is afterwards. Again, now she just has a small esophoria. It's really doing very well, even better than I had hoped for. Again, this distance near disparity collapsed without doing any of these slants or resections. So Dr. Waleed, are you still with me?
Yes.
Yeah. I have one more patient I want to show to you. This one is a little bit more straightforward. It's an acquired exotropia after visual loss. Is that common to see, acquired exotropia after visual loss in one eye?
This is most likely sensory exotropia.
Yeah, okay. So here's a teenager who was noted to have right exotropia and decreased vision. He was diagnosed with a chiasmal glioma and it was resected. After that, the exotropia improved. It was much bigger, but there's still a residual exotropia. He's 2200 in the right eye. He has no afferent defect. He has no significant refractive error, no diplopia. His ductions are full, and he has a right exotropia of 40 prism diopters. So what do you think about this case? Does it make sense?
So the child, since he had the chiasmal glioma in late childhood, that's why he developed sensory exotropia. So in this case, since it did not resolve, I would do a visual field.
Visual field. Okay. What are you looking for?
To look for any visual field defect caused by the chiasmal glioma resected.
Okay, that's excellent. You know, that's really excellent. And I want to point out, though, there's one thing on this exam that doesn't make sense and should raise a red flag. And you nailed it. I'm very impressed by your answer. But even before you move to the visual field, there's something on this exam that doesn't make sense.
The absence of APD.
Absolutely. Absolutely. There's no way that a child has a unilateral optic neuropathy causing a sensory exotropia and decreased vision to that degree without an APD. So this is telling you that either the visual loss is not from the optic nerve, or there's optic nerve damage in both eyes. Because you can have optic nerve damage without loss of visual acuity, right?
Yes.
Yeah. So we'll take your advice, we'll do a visual field, and he's got a bitemporal hemianopsia, okay, from his chiasmal defect. His exotropia, you can almost consider his exotropia as an adaptation, because his temporal visual field was, he didn't have temporal visual field. With the exotropia, he has more of a panoramic field of vision. It's important to note this because when you do surgery for him for his exotropia, his field of vision has become less, and he might become very upset with you. But in my experience, actually, most of these patients who have bitemporal hemianopsias or visual field defects and exotropia, they're so bothered by the appearance of the exotropia, they don't mind that when their eye is straight, that their visual field constricts. But you better explain that to the patient beforehand, because if they're not ready for that and they don't like it, they'll be very upset afterwards. So thank you, Dr. Lee, that was excellent.
You're welcome.
Yeah. And here we go, of course, chiasma, bitemporal hemianopsia. No APD, it's not a unilateral optic nerve problem in that setting. Okay, who's the next one? This one, again, we're going to non-strabismus now. Let's see what it is. Abnormal disc. Oh, that's easy. Let's see. Dr. Khalid, can you pick somebody for me? If somebody doesn't want to volunteer.
Sure.
Khalid, I would love to have contribution from others, please. Non-KSU, please.
Sure, no problem. Can we have Dr. Faisal Al-Anizi?
Yes, I'm here.
Dr. Faisal, what year are you?
R2, I'm from the Joint Program.
Excellent. So if you're called because you're being referred a 9-year-old boy with headaches and an optometrist said he has disc elevation, what kind of things do you think about?
Space occupying lesions, raised intracranial pressure, trauma.
What was the first thing?
Space occupying lesion, any brain lesions, or
So
optic tract?
even before you say the brain lesion, I would say you would think that the disc elevation is from raised intracranial pressure. So you're thinking
Yes,
it's papilledema, because disc elevation is not automatically papilledema,
yes.
right? There are different causes for disc elevation. So absolutely, you have a patient, it's somebody who's referred with disc elevation and headaches. You automatically are concerned about increased intracranial pressure, no question about that.
Mm-hmm.
What kind of things would cause increased intracranial pressure in a child? Especially
Maybe
in obese. Yeah.
if it's secondary to trauma, I'd be thinking about intracranial hemorrhages. I should always rule out intracranial lesions and masses.
Definitely. But if we're going to talk about common things, especially if this is an obese boy.
Unlikely to happen, but the IIH could present with such age.
Yes, it is unlikely, but it's increasing in incidence with the increased obesity.
Yeah.
So the number of pediatric cases is actually increasing, and it's directly related to obesity. Good. So this is a 9-year-old boy. He was actually diagnosed with optic nerve swelling 5 years ago. And he had an extensive neurological workup. He even went to Europe for part of it. And he's even had lumbar puncture. Everything has been normal, MRIs, blood tests, but he continues to feel worse, continuing headaches, decreasing vision, and he's referred for a second opinion. So this is the situation.
Okay. So I'd love to start.
Yeah, well, let's look at him. He's wearing glasses. He was refracted recently. And with these glasses, he's 20/25 vision. And he has a small esophoria with his glasses.
Okay. So I'd love to have more on the history of the patient. I want to ask first of all about the incidence of his complaint. Since when did it start exactly? Was there any previous histories or of trauma or decreases of vision? I want also to ask about history of diet and changes in diet, like some vitamin deficiencies would give us some, it would explain some of his neurological issue. Also, I want to ask about medications. Is he taking any medication to rule out medication-related raises in intracranial pressure?
Okay. How about we take a look at his discs?
After the history, then we'll start with the doing the physical exam, starting with the VA, extraocular motility, and the relative afferent pupillary defect. Then we'll do the slit lamp examination.
Okay. Well, let's go right to his discs. These are pictures. They're not 3 dimensions. But would you agree that there's disc swelling there?
Yeah, kind of.
You can see that these discs are elevated.
Yeah.
You can see by the way the vessels are going.
Yep.
Okay. Here's an OCT. It shows that definitely there's elevation of the disc.
I'm more concerned about like on the physical exam, there seems like granular deposits or like adrosin on the disc. Can you go back to the previous picture?
Yeah, I'm back.
Like on the right eye, near the shunt, there is like some deposits or granular elevation, not on the temporal aspect of the disc, I think.
Yeah, yeah. Can you tell if we're concerned whether or not there's papilledema, right? This is really the question.
Okay.
Can you tell if can a OCT tell us if there's papilledema?
And it can, but unreliable, according to Dr. Majid Al-Abidan yesterday's
It is definitely, Dr. Majid Al-Abidan is 100% correct.
But I think he's better to have a B scan or A scan
Sure.
for the optic disc.
So you're suspecting that there's drusen?
Yes.
Okay. You know, you cannot, I want to really highlight, there are signs that can be suspicious for papilledema in an OCT, but no way can you be sure from an OCT alone whether or not there's papilledema. And I really, that's a very strong point that needs to be made. Certainly it can be very suggestive, but it's never 100%.
Yes.
So I want to go back to this here, this history, and there's something in this picture that is bothering me in this history. And this is what bothers anybody, any pediatric ophthalmologist who does strabismus. This child has a small esophoria, okay? Anybody who has headaches and an esophoria needs a cycloplegic refraction. Anybody who has headaches and esophoria needs a cycloplegic refraction. And when we do a cycloplegic refraction on him, he's +7. They never did a cycloplegic refraction on him. They did a manifest refraction on him and they got this +2. He's been feeling worse, headaches, decreasing vision because he's been a latent hyperope. And the clue is this small esophoria. And so we give him the full cycloplegic refraction and atropine. 1 month later, he's 20/50 with the glasses, and he has an exophoria, and he's blurred. 2 months later, he's 20/40. He's difficulty with distance still. But 6 months later, he's 20/20. He loves the glasses. He won't take them off. The thing is, for all his life, he's been accommodating that high hyperopia, and it took him a while to give it up. But now he's so comfortable, and he loves his glasses. And this makes us more comfortable that these are drusen, because drusen go with high hyperopia. It's very common to see drusen in high hyperopia. The other thing about these discs, do you see how there are multiple branches here off of the disc? It's kind of smallish too. I don't have a picture of the fovea to show you the disc fovea distance, but this is the lumpy, bumpy disc that we often see in high hyperopia. So this child had uncorrected hyperopia, and this is why he had headaches, and nobody had ever done a cycloplegic refraction. Anybody who has headaches and decreased vision, especially if there's an esophoria, should have a cycloplegic refraction. Okay?
Yeah,
Great job.
Thank you.
Great job. We have one more abnormal disc and nystagmus. Dr. Faisal, I'm going to keep you for this one also. I just want to ask your opinion on the appearance of this disc. This is a 6-year-old girl who has long-standing nystagmus. She's small for age, she's a poor eater, and she's a glaucoma suspect. She has decreased vision, she doesn't have high pressure, she has nystagmus with an abnormal head position, and she has a refractive error. But she's referred because of these abnormal discs, and I just want you to describe the discs to me, that's all.
Okay.
What do you think about that disc?
Pale optic disc. I think there is effacement of the vascular, the vessels of the disc, superiorly and inferiorly. So, and there is blackish pigmentation on the temporal side. It's more like of, I'm not sure if it's a lost tissue or what exactly.
Very nice. Yeah.
And there's peripapillary atrophy.
Good. And anything additional on the other one or similar?
The other ones, the vessel seems to be radial on orientation.
Okay, you know, very good. I like how you're describing it. Now, let me tell you that, you know, there are very few pathognomonic optic nerve appearances. And this is one of the pathognomonic optic nerve appearances.
It's similar to the morning glory syndrome.
It is similar, but it's not. Because in the morning glory, what you actually have is, I'm sorry, you have an enlarged disc that sits in an excavation with glial tissue in the center and multiple radial vessels. This is, I can see why you'd say this is similar, but it's different because you don't have, it's not sitting in an excavation, and there is no central retinal artery circulation. Normally, in a disc, we have a central retinal vessels coming from the center, right, and coming. As you mentioned, these vessels are all coming from the side. You see that? They're not coming from the center. The disc is empty. Sometimes this disc is called an empty disc in the literature, or a vacant disc. These vessels, I mean, you don't know it from looking, but very often these vessels are cilioretinal vessels. And the vasculature in this retina is subnormal. That's why there's all of this atrophy here. This is a classic appearance for the disc in the papillorenal syndrome.
Okay.
Which is a, I mean, I didn't expect you to know that. I just asking for your description, and your description is good, but now you know it. If you ever see this, this is the pathognomonic disc of the papillorenal syndrome. It's a defect of angiogenesis that primarily affects the optic nerve and the kidney. And it's classic in that the disc is empty. See this? It's called an empty disc. Do you see what I mean by that? How there's nothing here. All of these vessels coming on from the outside. You're right, there's a similarity to morning glory, but it's different. Morning glory isn't empty like this. And morning glory has glial tissue in the center. And morning glory sits in an excavation. And usually morning glory is unilateral. This is bilateral. And it's the papillorenal syndrome disc. And as I mentioned, this girl, whoops, she was small for age and a poor eater. She's in renal failure. And when we worked her up, we found she has a small dysfunctional right kidney and a multi-cystic dysplastic left kidney. So the papillorenal syndrome, it used to be called the renal coloboma syndrome because this was thought to be an optic nerve coloboma, but it's not. And we shouldn't use the term renal coloboma syndrome. It's not a coloboma. Coloboma is a different mechanism. This is an abnormality of angiogenesis. It's characterized by optic disc and kidney abnormalities. It's due to mutation in this gene, but actually the optic disc appearance is more specific than the gene mutation. So some patients don't have mutation in the gene, but they actually have the syndrome. And again, that optic disc abnormality is classic. Again, vacant disc, absent and minimal central retinal artery, multiple cilioretinal vessels, very specific for this condition. And I'm happy to share this with you because we see it. It's autosomal dominant. It's not more common in the region than other regions of the world, but we see it. And I'll tell you, if you go to the adult glaucoma clinics and you pull out all of the charts of patients who were diagnosed with low tension glaucoma, and then from those charts, you find the patients who had idiopathic renal failure. Some of those patients are papillorenal syndrome. They never had glaucoma. You know, it's often because they do have visual field defects, and it kind of looks like, especially if you see an adult like this, you might think that it's a glaucoma, but it's a congenital abnormality. Okay, now I don't know, do we keep going or do we have to stop because of time? How much time do we have?
We can continue, no problem. How many cases left, doctor, if I may ask?
I don't know, maybe 3 or 4 more cases.
Yeah, no problem. We can go on.
Depends how long we discuss. I can just go and we can finish them. Here's one where the eyes don't move together. I need an R4 for this one.
Thank you, doctor.
Thank you, Dr. Can you see anybody on the list there?
We have Abdurrahman Sahibani, I guess.
Dr. Abdul Rahman, are you there? This is a very quick one. Actually, I will go through it. This girl, the left eye goes down in side gaze. Somebody speaking? Okay. So here she is. When she looks to the right, you can see that the left eye goes up. That is over elevation and adduction. You can call it inferior oblique overaction if you like. But then, when we look this way, she has this bizarre thing where the left eye is going down. And this is the complaint of the family. So how can we explain that? Well, it's actually a very simple concept that we forget about all the time. When we're checking the versions, we assume that the eye closest to the target is the eye that's looking at the target. But sometimes the patient will look with the other eye. And what's happening here is the patient is actually looking with this eye, and this eye is going down. Had she been looking with this eye would be going up with the inferior oblique overaction, just like it's happening here. So when we tell her to look with the right eye, with the left eye, sorry, she has the expected inferior oblique overaction here. You see this? This is an important concept. Whenever a patient, you're checking ductions in a patient, versions in a patient, and you have an abnormality, you have to check the duction also because you don't know which eye they're fixating with. So here, she fixates with this eye, this is what we're expecting, but over here, she's fixating with this eye is going down instead of this one going up because she's fixating with this eye instead of this eye. When she fixates with the left eye, the right eye goes up as expected. Is that clear? Yeah, okay. Now, I need a resident to talk about this one. Again, this is straightforward. This is Duane syndrome. And I think I'll make this my last case. Dr. Khalid, we have anybody?
And we have Dr. Ibtihaj. Is it okay to have an R1? Because I think she wanted
to
talk.
Sure.
Hello.
Hello. Assalamu alaikum.
Assalamu alaikum. Alhamdulillah.
What do you know about Duane syndrome? Do you know anything about Duane syndrome?
Yes, Duane syndrome. The pathology is that there is absent dysgenesis of the abducens nucleus. So there is innervation to the lateral rectus muscle by the oculomotor nerve.
Okay, good. When do we operate on Duane syndrome? Any idea?
There is indications. I think if he's not ortho in primary position, and there are other indications.
Very good. So as you said, Duane syndrome is usually in girls, and it's usually on the left side, just like this girl here. And it's an abnormality. It's the sixth nerve nucleus is supposed to innervate the lateral rectus. Something goes wrong, and that innervation doesn't get to the lateral rectus completely. It can be 90% doesn't get to it, or it could be only 1%. So there's a huge variation in how much abduction there is. The lateral rectus muscle didn't get its full innervation and it's hungry. So it starts crying. It says, give me innervation, give me innervation. And the third nerve nucleus hears that. And some of the fibers that were destined for the medial rectus go over to the lateral rectus inappropriately. And it can be a lot of fibers or it can be very few fibers. And depending on how much, you can get different degrees of inappropriate co-contraction of the lateral rectus and the medial rectus when the patient tries to adduct, because inappropriate innervation has gone to the lateral rectus. And you can see in this girl with Duane syndrome in the left eye, when she tries to look to the right, she can adduct fine, but there's some co-contraction. That's why the palpebral fissure is smaller, because the lateral rectus is inappropriately contracting at the same time. And when she abducts, she cannot abduct fully because the lateral rectus was not appropriately innervated by the sixth nerve nucleus. The indication for surgery in Duane syndrome is if we have a significant abnormal head position or if there's significant strabismus in primary. So this girl, does she look like she needs strabismus surgery? Does she look like she has a significant abnormal head position when she's looking straight ahead?
Yeah, yes, there is like a left head turn.
There's a left head turn, there's a left face turn, but it's quite small. So this family came to me and said, asked me if she needs surgery. I said no. I mean, you could consider surgery. She does have a smaller appearance of the eye, and you could consider surgery of both the medial and lateral to make the eye more prominent, but they weren't bothered by that. Actually, they weren't bothered by anything. They weren't bothered by this minimal face turn, so there was no indication for surgery in this patient. Okay, because there's no significant face turn, and they're not bothered by the position. Unfortunately, the family later went to a different doctor, and that doctor recommended strabismus surgery. Not only did they recommend strabismus surgery, they recommended a medial rectus recession of 7. Now, Dr. Ibtihaj.
Yes.
I told you that in Duane syndrome, when the patient tries to adduct the eye, the lateral rectus fires inappropriately. So both the medial rectus and the lateral rectus are firing at the same time. So there's a tug of war between them, correct?
Yeah.
What do you think is going to happen if you do a very large weakening procedure to the medial rectus?
Weakening procedure?
Yeah, because this patient had a medial rectus recession of 7 millimeters, which is quite large.
I think it will lead to more contraction and worsening of symptoms.
Well, if the lateral rectus and medial rectus are in a tug of war, and you weaken the medial rectus, who's going to win the tug of war?
The lateral rectus.
That's right. You never should do a large medial rectus recession in Duane syndrome when there's significant co-contraction. But unfortunately, that's what somebody did for this girl. So what happened to her? She came with a large face turn in the opposite direction. Because now the lateral rectus wins, the medial rectus is practically crippled. And whenever she tries to adduct this eye, the lateral rectus is inappropriately working and the eye goes out. And you can see here, if we force her, she has an opposite face turn because she needs to keep this eye now in abduction. Before she kept the eye in slight adduction. Now she keeps it in abduction because this medial rectus has been crippled. So when her head is held straight ahead and she's forced to look straight ahead, This eye is out. That's why she likes to turn her face to the right. So this eye can be aligned with this eye. And when we when we make her look this way, here's that tug of war between the lateral rectus and the medial rectus. The medial rectus has no chance, and she cannot adduct that eye. And this way is fine because the lateral rectus, although it's a little bit limited, the lateral rectus is working. So this is something that should never be done. When you have a patient with Duane syndrome and significant co-contraction, you have to be very careful about recessing the medial rectus in that eye. So how do we manage such a patient? Well, you know, this is quite a problem now because in Duane syndrome, the medial rectus to start off with is quite tight and contracted. Now we have a situation where the medial rectus is tight and contracted and recessed in this eye. So it's going to be very difficult to bring that medial rectus forward. Also, in my experience, is when it's recessed like that and you bring it forward, you get all of this fatty tissue also with it, and it doesn't look very good. So really, the only solution here is to recess this lateral rectus, although I'm not thrilled about it, because if we have to recess this lateral rectus, we're going to limit the movement in this eye. But we have no choice because we cannot leave her like this with this large face turn to the right. So what we did was we went in, I looked at the left medial rectus. It was far back and too tight. Advancement would have caused fat to come up. So we did a large left lateral rectus recession. And here she is now, her head is straight and she's much better off. But of course now that left eye is going to be limited. And she's limited in movement in that eye because the medial rectus is so far back, it cannot work properly. And the lateral rectus now is recessed and difficult for it to function as well. So, thank you very much, Dr.
Thank you, Doctor.
Dr. Khalid, I'm not looking at the chat. I have no idea if there are any questions or anything about any of these cases.
We did not get questions regarding cases.
Okay. If there's no question, the cases must be too easy then. If there are no questions, then I have one more case I'll share. It's a hyphema case. Who can we give the hyphema to?
We can have Dr. Abdul Wahab.
السلام عليكم دكتور عارف.
وعليكم السلام، كيف الحال؟
الحمد لله. How are you?
Good. كيف الأمور؟
الحمد لله أبشرك تمام.
So what do you think about hyphema in a child?
So we can divide it either traumatic hyphema or spontaneous hyphema.
Most common would be?
Traumatic.
Definitely. So here's a 6-year-old girl with a history of congenital glaucoma and ophthalmos. She's had multiple glaucoma surgeries, including tubes. The left eye is her better eye. She fell and hit her right eye in the playground, and blood was noted in the eye, and she referred 3 days after the event to me. And she's LP, count fingers, and her pressure is high in the right eye. And there she is. So what do you think we should do with her?
Mm-hmm. Of course, we will start with taking history. As you said, Doctor, she's a known case of glaucoma.
Yeah.
So
I mean, let's say that all of this history is the complete history. Okay, so we have the complete history.
Mm-hmm.
And we don't have the reports, but she's had multiple glaucoma surgeries, including tubes. She fell, hit her right eye in the playground, blood, vision LP, count fingers, pressure's high in that eye. How do we manage her?
Okay, we will start by examining this patient. take visual acuity, as you said, light perception. Also take the visual acuity in the other eye. Okay.
Yeah. Count fingers.
After that, what I can see here, an anterior segment photo showing maybe this is 2 millimeter or 2.5 maybe millimeter hyphema. Also, I can see here a corneal opacity in the center. Okay.
So what should we do? This is kind of an acute situation.
Again, doctor.
How do we manage these hyphemas? I mean, it's sort of an acute situation. Anybody can answer in the chat also. Although I don't see the chat. What's the approach for hyphema?
Somebody in the chat mentioned check the tube. I'm just reading what you have written. Somebody mentioned atropine.
Okay.
And then somebody is concerned about the pressure.
Yes, I'm concerned about the pressure. Yeah, yeah. But, you know, we also are concerned about the retina, of course. So, you know, we want to get a B scan. Okay. So the retina is intact. But is there anything else that we worry about in hyphema?
Yes, the IOP, doctor.
Yeah, yeah. But is there anybody who in particular has a problem with IOP?
The sickle cell patient.
Yes, yes, yes. So we have to check for sickle cell trait, sickle negative. Okay. So, you know, what do we, hyphema, you know, can cause damage, and, you know, hyphema is prone to rebleeds. So we want to tell them to take it easy, use drops, start her on anti-glaucoma drops, and hopefully it will clear up, right? This is a high-risk eye, a ophthalmic eye. So we tell her all that, we start her on drops, and she comes back like this.
Mm-hmm. So she might have an attack of rebleeding.
Yeah, definitely. Definitely.
So we have to check the IOP again, and also do the scan.
Mid-20s.
One of the residents mentioned corneal staining.
Yeah, so this is a concern. This is a bad situation. And, you know, it's a difficult situation. But what makes it even more difficult is that this is a ophthalmic eye and has had multiple surgeries. And if you just do a paracentesis in this eye, you can have a suprachoroidal hemorrhage. I mean, it's such a high-risk eye. So this was the worst eye of the two eyes. And I'll tell you that, you know, this is kind of a difficult situation. But because it's so high risk, we decided to just wait and encourage her to relax. And the pressure, you know, with time, it cleared. Then we were able to refract her, and her vision came back, and she lived happily ever after. But the thing is, what I want to stress is, you see a situation like this, I think there's a lot of pressure to intervene. But sometimes when we intervene in these situations, we make matters worse than they would have been in the natural course. So, you know, obviously, this was not an easy situation. It was a high-risk situation, but conservative management, atropine drops, rest, and it cleared up, and she did well. So yeah, I have more cases, but I think the time is up. So if there are no questions, we can.
Questions. If I may ask about the Duane case, the Duane syndrome. Yeah. If the family were bothered by the look of the eye, I mean, like they say it's like kind of small, or it's the eyes inward, what would be the surgical management for such case?
You can do recession of the medial rectus and recession of the lateral rectus in the same eye. and that would actually bring the eye forward.
Yeah, but
And
how
if
many
the,
millimeters would you go? Because as you mentioned, large recession will cause very huge limitation of the movement.
yeah, no, I wouldn't make it so large like that, but you're also going to balance it with the recession of the lateral rectus. I mean, 7 millimeters is a very large recession. It's really, really a large recession. I can't give you a number, you know, this is judgment for how much I would do in this case, but it's very rare that somebody does a 7 millimeter recession. So that was really a bad move for this patient. But when you do a balanced recession, and how much would I do? You know, it depends on the feel. I would probably do around 5 for the medial rectus and a little bit more for the lateral rectus, because you have to do more to get the same effect on the lateral. But then I might decrease the amount of recession on the lateral rectus a little bit if there's a small esotropia, and there is a small esotropia in her. So that's definitely an option. But I'm not going to tell them that they need it. You know, this family had no concerns with the appearance of that. And they said they only wanted surgery if they needed it. And they certainly didn't need it. And unfortunately, that's not what somebody else told them. But you can do that. You can recess both the medial and the lateral to make the eye appearance a little bit bigger in Duane syndrome. You don't do these huge numbers though.
I see. We have another question regarding the hyphema case. What if the patient was of a younger age? Would you interfere earlier because of the risk of amblyopia?
It's a very difficult situation. I mean, in that particular case with the buphthalmus and the multiple surgeries, you know, we have what's written in the textbook and what happens in real life. And in the textbook, it's a perfect world and everything fits in the margin, and there's a right answer, there's A, B, C, and D, and there's only one correct answer, and that's the textbook. But in real life is messy. And in this girl, her buphthalmic eye, multiple surgeries, tube, such a high risk to go in that eye. And it was the non-preferred eye already. I mean, it was already an amblyopic eye from before. So in that context, I wanted to be more conservative. Now, I probably still would have waited because of the high risk of this buphthalmic eye, even if the child was younger. But if things persisted for a longer time, we've been forced to go in. But it's not an easy thing. It's a high risk situation to go in. Sometimes this is where judgment comes in the real world.
I see. In the chat, we don't have any more questions. Yeah, we have regarding the child with headache and esophoria. Would you give the glasses prescription gradually, decrease the need for atropine?
That's an option, but for him, he was suffering because of his accommodation. And, you know, I see a surprisingly large number of these patients. I mean, actually, I'm shocked how many patients I see like this. It seems like people are not into cycloplegic refractions for older children. And my approach to them really is I just give them the full hyperopic correction and I give them atropine, and it always works. And it will work faster by doing that than giving them gradual increases in the prescription. The problem is that muscle is in spasm. That ciliary muscle is in spasm. For his whole life, it's been in spasm. And it's very hard for it to relax. And the atropine, in addition to making it easier for him to get the glasses, is also forcing the muscle to relax. So theoretically, you can do that again, you know, with the gradual increase in the prescription. But practically speaking, it'll be much faster and in the long run, much better for the patient to just get him on the glasses with the atropine. Atropine is a great drug, by the way. I like it for these patients who are latent hyperopes. For that patient with hyphema, it's a great drug with hyphema. In hyphema also, not only besides relaxing the ciliary muscle, it has an anti-inflammatory effect, so you don't need to use as much steroids. It's very good for treating amblyopia in patients who will not tolerate patches. It really has a lot of uses in pediatric ophthalmology.
Thank you, Dr.
one
Khan. There is a question from Muhammad Atabi, but I'd like him to explain if he can ask the question himself.
Yeah, sure. Thank you so much, Dr. Khan, for giving us part of your time. I just want to ask regarding the case of the visual loss. You said that it's an adaptive state where the patient is trying to enhance the visual field, right? So if they are concerned,
that's what I would think. You know, I can't prove that, but it makes sense, you know, thinking that way. Yeah.
Okay. So if the patient is concerned about the strabismus, would operating on the patient like have a risk of diplopia post-op or?
Well, you know, that's a very good question because, you know, some patients with bitemporal hemianopsia on their own, you know, why don't we have diplopia? Why don't any of us have diplopia? Because we have corresponding visual fields in both eyes, right? Corresponding spots. And if we are visually mature and the corresponding points on retina in the right eye don't match the corresponding spots in the left eye, we see diplopia if there's a misalignment. Now, if you have a visually mature adult who gets a bitemporal hemianopsia, a large one, sometimes the loss of that temporal visual field, it depends on how good their binocularity is. Sometimes they get a slip. It's called a hemifield slip. And they actually start to get diplopia because their nasal visual field is not enough to keep their eyes aligned. So that can happen even in a patient who didn't develop an overt strabismus. So for this patient, there definitely is a risk for diplopia when you get the eyes aligned and he's just got those nasal fields and there's decreased vision in one eye. There's a phenomenon called hemifield slide that can definitely happen in him. And it's definitely something to talk about before doing the surgery. So that's an excellent question and an excellent point.
Great, thank you so much.
Dr. Arif, we have a question regarding the aminocaproic acid and tranexamic acid for hyphema. What's your experience of using both agents?
Yeah, well, you know, that was in vogue for a while you know, I think in the 90s. But to be honest, I personally have never used it. And I really haven't found it a need for it. I find that these patients do very well with atropine and rest. But there have been some people, it was in style for a while, but I don't think many people are using it anymore. I think rest is the #1 treatment for these patients. I don't think it's, in my experience, I haven't been using it.
I see. Regarding the limbal dermoid excision, what are, you think, in your opinion, the indication? As you mentioned, the astigmatism will not be resolved after excision. So when do you go for excision of limbal dermoids?
Yeah, well, you know, it's true that it's really a reconstructive surgery. You know, the child has a grossly abnormal appearance. I wouldn't call it cosmetic. It's like if somebody doesn't have a nose or somebody has a large cleft palate or cleft lip. You do reconstructive surgery for a normal appearance. And this is obviously a grossly abnormal appearance. So if the parents are bothered by it and they want something done, that's an indication to do it. Sometimes, you know, these lesions are irritating. They're causing dry eye. The lid doesn't close properly because of it. You know, these are other indications. But again, unfortunately, the astigmatism doesn't tend to go away when you remove them. They're typically inferotemporal, as it was in this child, but rarely they're on the cornea itself. So obviously, if it's on the cornea, that's obstructing the visual axis, and that has to come out. But most of these peripheral ones, the indication is reconstructive surgery for a normal appearance, not really for visual function.
I see. I think by that we reached the end of the questions. I would like to thank you on behalf of all the attendees. Thank you very much for your informative and very great lecture.
Okay, thanks for hosting, and I hope you don't get in trouble now because you called on the people.
No, he will not.
I hope you still have friends now.
Well, yeah, well, Khalid, everybody likes him. Thank you for moderating, Khalid. And of course, thank you, Dr. Khan. It's always a pleasure to have you, and it's a great session. Thank you.
Congratulations on your excellent residency program. I hope to see you soon.
Hopefully, yes. Thank you very much. Regards to the family as well. Okay, take care.
Bye-bye. Bye-bye.
Bye.